Hello, everyone. My name is Dodd Kattman, and you are connecting to architecture and design in the COVID-19 environment. I hope you enjoy this. I hope there's some information here that you find that you can take home with you, that you can incorporate right away, or maybe things that you'll keep in the back of your mind and incorporate later. So here we are. How many of you remember the Jetsons? This is a popular cartoon back in the 60s, and this was a futuristic environment where we had flying cars, we had robots, but interestingly enough, we also had computers, we had virtual meetings in the Jetsons, and that's kind of the world that we've all been forced into now in the last 6 months with virtual meetings. So I thought it was so appropriate to use this. So what I'm going to do right now is get my face. I want to welcome you, but I will close that view and allow you to just see the slides. I think that will be less annoying. Let me tell you a bit about who I am and what we do and what we're passionate about. My name is Dodd Kattman, and I'm a principal at MKM Architecture and Design. We work actually throughout the country, throughout the Midwest, helping life plan communities and related providers with their building needs. And I shouldn't say building, really building planning needs. And I'm just so blessed. I'm so blessed, first of all, to be able to serve you, because what you have done in the last 5 months as you've balanced this disease, as you've cared for lives, as you have reinvented your operations, just amazes me. And I'm so lucky to be able to serve you. You guys rock. I mean, you are the best. And so I'm hopeful that whatever I'm able to share in this in some way makes your life a bit easier, and most of all helps you to serve the residents that you serve and keep them safe. So I've been working with life plan communities, like I said, for almost 30 years, but I think more importantly, I've had the opportunity to and I'm still involved with a national group that the American Institute of Architects uses to help educate all the architects around the country on design for aging issues. It's called the Design for Aging Knowledge Community Advisory Group. And what we do is search out best practices and help to communicate those best practices to all the other architects who don't take the time to try to understand these things. So I'm so lucky in that I have the ability and the time to do that, and I know with your busy jobs you don't have the time to focus on that. So use me as your resource. This allows me to understand those best practices, to find out what works and what doesn't work, and to share those with you so you don't have to focus on it. The MKM, we believe that individual well-being is essential for communities to thrive. And when I use the word community, it could mean your campus, it could mean your building, it could mean the city that you live and work and play in. And for you to thrive, for your residents to thrive, for the stakeholders to thrive, it's so important for us to nail that. And we work with stakeholders across that care continuum. In short, we design meaningful places for people. And we see that our work really being focused on this fulcrum or this balance between independence and health. And this is, if you were to draw a matrix and you had health on one axis and independence on the other, it's a tough balance to achieve. And we try to apply this balance through independent living buildings, assisted living, memory care, PACE programs, community centers, nursing homes. And interestingly enough, we do a lot of work for hospitals. And I think a lot of hospital practices have helped us to best understand how to, quote unquote, COVID-proof a building. Because as you know, hospitals have very aggressive risk staff, infection, risk control staff. So what we learn from those individuals, we also want to share with you through this presentation. I also know that being a virtual presentation, you may be listening to this in July of 2020. And as you know, we have not made it out the other side of this coronavirus outbreak yet. We're all still trying to figure this out as we go. If you're in Indiana, you are preparing to open your building up to visitors as we speak. And how scary is that? Additionally, I know that being a virtual presentation, you may be watching this in the year 2022, 2024, and even farther out. And hopefully this outbreak, this epidemic will be in our rearview mirror. Hopefully some people won't understand the realities of it looking back. So I'm going to take just a few minutes to put this in context. For everybody living this day to day today, bear with me here because I know you know this information, but to date, and these statistics were most recently reported by the New York Times on July 7th, 2020, is that the coronavirus has caused, by now, it's over 130,000 deaths just in the United States alone. We're over a quarter of the deaths in the world. This is scary. More than 42% of coronavirus deaths have been connected to nursing home residents or workers, and that is shocking. 10% of the U.S. cases in general relate to nursing homes, so that tells us that there are several cases within the nursing homes themselves who have had this virus break out in their building. It's infected more than 14,000 facilities across the United States, and this is, although only 10% of the cases relate to nursing homes, over 42% of the deaths relate to nursing homes, and you balance that with the fact that fewer than 1% of the United States population resides in a nursing home. That makes it even all the more frightening. So I've had some very frustrating conversations over the last few months with individuals who say, you know, this coronavirus, on one extreme, you know, you hear people use the word hoax. On the other, not too far from that extreme, you hear people say, well, this is just like the flu. It's no different. You know, the flu kills people every year. I don't know why we're getting so worked up about this. Well, that's just not true, because according to the CDC, in 2019, last year, as I'm taping this, only 0.1% of the U.S. population died from the flu. So far in 2020, over 5% of the individuals who came down with the coronavirus have died from the flu. And two, perhaps more relevant statistics, in 2019, if you're over age 65, statistically, 83 out of 10,000 individuals died from the flu, and that's scary enough on its own, but that's less than 1%. This isn't tightly correlated because of the age difference here, but the statistics I have available to me is that the coronavirus death rate in the age 85 plus cohort, over 30% of those have died who have come down with the disease. So no, this coronavirus is not the flu. It is 52 times, the death rate is 52 times higher than the flu. And another very frustrating conversation I've heard as well, the way we need to get rid of this is through herd immunity. And I'm sure you've heard this, and the science behind herd immunity is after, and I think with a virus like this, I think the CDC estimates it to be about 70%, but after 70% of a population is immunized, it almost stops the transmission of the virus. It doesn't stop it, but it almost stops it because there just aren't many people around to transmit it or get the virus. Well, this is such a maddening conversation to have, because when you think back of the statistics that we just shared, knowing how lethal this virus is, knowing that over 30% of the people on average that we serve will die who get this disease, to, in a cavalier manner, to just say, well, we need herd immunity, and they aren't necessarily saying that in the context of vaccines. I've heard it thrown out in the context of just general, let the virus, let people catch it, let it run its course, is just frustrating is not a good word to describe. So the learning objectives here is first, we're going to talk about access control and visitation, because that's certainly one way to help control an outbreak in your own building. We know that the coronavirus, or hopefully in the future, again, this will be applied to the influenza or some other virus, we know they don't start in your building. We know they walk into your building through staff, visitors, vendors, whoever it might be. So we're going to talk a little bit about how to keep it out of your building in the first place. We'll talk a bit about the benefits that what we'll call small house design or neighborhood design, you might also call it, some people generically call it greenhouses, whatever. We'll talk about some of the attributes of this type of building planning that will really help you manage an outbreak of a disease. We know you all don't have buildings that are set up this way, so we're hopeful that some of the attributes that we'll talk about in that discussion will help you apply them to your own building or to future buildings that you may plan and build. Additionally, from a day-to-day aspect, we've been asked to produce white papers on dining, on creating negative air rooms, converting resident rooms to negative air. So we'll talk a bit about dining room planning, dining room modifications, and how to think about your resident rooms. So let's talk about access control. These technologies have been around for a while, but they're really catching a lot of momentum right now. This happens to be AccuShield. We're not advocating for AccuShield, but we've heard good things about this technology. So one of the strategies that campuses are incorporating is a screening process, and now that we've gone through this outbreak, companies like AccuShield have added a thermometer and a scanning add-on to this registration and background check software that they have to help you identify somebody who might be contagious and perhaps may not know it yet. People are using these for visitors coming in the building. People are using these to screen staff to make sure that care staff aren't bringing the disease either unknowingly in your building, or they may have a small fever and that paycheck is too important to their family and they need to work, and this may be a way that you can catch that before it makes it into the building. It could be people like me, other vendors, as well as if you're managing an independent living or assisted living building, screening residents coming back into your building who might have gone out into the building during an outbreak, and making sure that they're not bringing something into your building. Your policies may be to quarantine those people. I know many that we talk to are quarantining residents that might be going to church or doing something else in the community. So I'm not advocating for technology, but the reason for talking about this is this affects the entrances, because in order to use this technology well, you really need a staffed location, although there are ways to do this without staffing a location. This relates to how many front doors you're allowing people to use. This relates to where people are parking. So it does have a planning impact in thinking about where people come into your building during an outbreak, and do you want to incorporate a technology to this really has upstream effect on building planning. We're also balancing this access control concept to the reality that we believe one of our greatest goals in partnering with you and planning life plan communities, whether it be nursing, assisted, memory care, independent living, whatever it might be, is that we know that loneliness has mental impact, has a psychological impact, but also has a physical impact on those residents that we serve. So we know that one of our biggest goals is to help through building planning to cure loneliness, and how we design our buildings to allow family visits, to allow people to come and go, to be in contact with others, it impacts loneliness. I mentioned we're going to talk about this a bit later, these household, neighborhoods, small house, greenhouse, whatever you want to call them. But I need to at least introduce the topic here because it will impact the entrance discussion that we'll have, or the access control. Small houses tend to be defined by how many residents live, sleep, and dine together, and they're additionally defined by, oftentimes, by how staff who are dedicated to a certain small house environment, just from a work standpoint and also from a relationship and knowing the resident better. They tend to be clusters of 10 to 18 private rooms. They tend to have their own showers. But what applies to this next discussion is small houses tend to have their own dedicated entrance to the outside for staff visitation sometimes, for family visitation, but also perhaps for staff and vendors to enter the building. So that's the piece that we'll focus on in these next few slides. And I'm going to use Byron Wellness Community as an example for some of these. So Deb and Sarah, thank you for allowing me to talk a bit about your building. This is a brand new building. This building opened to serve residents during the COVID outbreak. So they've been in their building as of mid-July for, I don't remember, about 6 weeks. The public has not been allowed inside their building yet by state regulation. But the initial feedback that we're hearing from those who work there, from those who manage and operate this campus, is that it's working very well from a COVID standpoint. So we want to talk about a few of those attributes that we think might be helping this building to work well. So in general, Byron is set up of 5 healthcare neighborhoods of 24 each, and those neighborhoods of 24 are broken down even further into 2 small house groupings of 12 residents each. And each one of these households has a front door, which is includes a front porch. It's identified by the yellow circles on the slide that you may be looking at now. And there's also one main entrance to the common amenities in the building, which link to all of the separate small houses. And that main entrance is illustrated by the pink circle on the diagram. There's an additional neighborhood to the upper right, but that's licensed residential, and we're not going to focus on that in this discussion right now. What these individual, this shows just a general layout, just to orient you with how these households of 24, again, broken down into 2 small house groupings of 12 each. We have a front door for visitors to enter, which is identified by that gold rectangle in the upper right. The light peach colored areas are resident living and dining and social spaces, as well as the preparation kitchen and access to the outdoor courtyards, which we'll talk about later. Each subgrouping of 10 to 12 or of 12 resident rooms also has a den. These dens can be activity areas, they can be visitation areas, they can be sensory rooms, and they might be set up differently in each neighborhood. But each one of these areas, each one of these small groupings of 12 are interconnected by sort of the service and support spaces in the middle, which includes office, nurse station, dietary, tub room, and some other support spaces. So in an outbreak, staff can help make sure that the residents are staying in their own half of their 12 resident small house groupings, or during normal operations, residents really can have access to any of those peach colors or any of the other common areas. So we're going to focus on this area in the upper right, which is the visitor entrance or the front door to each one of these neighborhoods. So when I enter this front door, I have a front porch. And we love the idea of a front porch just for visitation. All the neighborhoods have their own front porch. But the way we see this serving Byron so well in an outbreak, whether, again, it be influenza, H1N1, COVID, whatever it might be, we have a small place. We have these wonderful rocking chairs, a small place for residents and family members to visit without walking into your building. We'll talk more about that in a minute. So this is a way to keep something out of your building entirely, although certainly you want to make sure that a family member visiting a resident does not have the disease and doesn't share that disease with a resident on the front porch just for that resident to bring it back into the building. So if we cut the roof off of this building, to give you an idea how this works, and I think how it's working well now for Byron, is there's I'm going to call it a foyer, and that's what our homes have, right? Foyers. Our homes don't tend to have vestibules. We have foyers. So the foyer is really this family entrance. It can become a vendor or service entrance if their task is focused on that neighborhood and not in the common building. So they have the ability to secure the outside door to keep visitors out, and they allow people in electronically through the outside door, or they can leave the outside door open and they can secure this door to the interior. So it gives staff the ability to decide who enters the building, how far they come into the building, and for the staff to know a bit more about those people entering before they provide access. You could have these electronic screening devices in each one of these neighborhoods. Although I will tell you that Byron's goal is not to have somebody sitting in this nursing office right beside that, that entry foyer. Their job is to be out on the floor, but there are times when they need acoustical privacy. There are times they need to get work done, and they're in there. So that's why we have that located right next to the front entrance. It helps staff monitor who's coming and going from the building. You can see there's a window where they can see who's coming and going. There could be a window into the foyer, and certainly there's a window that they can see into the building and some of the back halls of the building. Most importantly, I think here, or equally importantly, is we have a family room right next to this secure foyer. And the way that family room might work, we're showing it with a conference table, and it could be set up with a conference table. This at Byron may more likely be set up like a family room, which is why we're calling it a family room. And these rooms are purposefully located by this entry foyer so that those, say I'm coming to visit my mother and I'm having a care planning meeting with staff. Byron personnel can allow me into this family room without me walking deeper into the building when we're dealing with times, say, during the flu outbreak. And that can help contain a potentially infectious person to an area of the building where residents aren't spending as much time. We've all learned fairly recently that with the coronavirus, it's this airborne aerosol, which is the most common way that the disease spreads. So this is a way to contain that in a building. I might be showing up just to visit my mother in this building. I might be showing up for a care planning meeting with staff. It could be a telemedicine visit. We could set this room up with cameras and television so that this could become a telemedicine room. I could also have, getting into that isolation and loneliness, I could also have, in worst case shutdown, I could have a virtual meeting with mom on a big TV screen where we can hear each other. They can see my face, bigger than life, for better or for worse. and it just gives us an ability to have those type of interactions. This is a building that's been around for a while. We've talked about it for different reasons in the past, but there's an element of this building that I think may be helpful for you. This is Catherine's Cottage for the poor handmaids in Donaldson, and originally we planned this. We wanted this to be very home-like and purposely planned this large front porch that you can see in the middle of the image. But for different reasons, we also included at the end of each one of these wings these small, more personal private meeting porches. We weren't thinking of the flu. We weren't thinking of the coronavirus. What we were thinking of at that time was to provide residents living in this early stage memory care assisted living building to have the ability to get outside in a small private and sheltered setting and have interactions just perhaps with one or two others or all by themselves. It just gives you a wonderful way to socially connect on a smaller scale, and some of us feel like we don't want to talk to a lot of people some days. But what we've learned is this strategy could be especially helpful in an outbreak of a virus, because what we could do is allow family visitations on these outdoor porches in a way that they don't bring the virus into the building. And I'll show you an image next of the interior of these spaces. These are all set up just with a couple chairs, again, to encourage the small gathering, acoustically isolated from the rest of the building. But it might allow a family member to visit at the end of these halls inside the building. It certainly allows a family member to visit on these outdoor porches and keep those individuals out of the building. Or worst case, when you want no connection from the inside to outside, there's about 6 foot of glass here with this door and the side light. It allows the resident to meet through the glass with a family member that never enters the building. So these small porches could be a wonderful solution for you moving forward. Briefly jumping back into the Byron campus, one thing that was intentionally designed here is Byron believes in saying yes to residents. They don't believe in saying no, even when residents want to go outside. And I know for so many of us, it's hard to encourage outdoor visitation because they need one-on-one staff attention. Well, this building was purposefully planned with these social parts of the individual neighborhoods with a lot of glass looking out into these secure outdoor neighborhoods, which allows staff to let those residents come and go as they please, and the staff can passively monitor them. Now, this is when it's safe. We've provided an automatic door opener at the door that accesses these courtyards, so the residents don't need staff assist to go outside. But if it's 30 degrees out and raining hard and we don't want somebody to walk outside who might be battling memory issues, they can also lock that door. But it's important to know that each one of these outdoor neighborhoods can be used as a wonderful escape, a respite, a visitation for family members who might be allowed either to enter these outdoor neighborhood or these outdoor courtyards through the neighborhood, or there's a separate exterior gate where you might be able to allow visitors to enter and have an outdoor event, visitation with somebody living in the building. There's walking paths, there's small gathering spaces. If I zoom in on one of them, this happens to be the larger neighborhood that's actually shared between their licensed residential Miller's Place and one of their healthcare neighborhoods. But there's a lot of connections to these neighborhoods from the indoor to the outdoor through these small circles. And there's actually a pavilion at the end of this shown at the right, which can also allow bigger events. It could allow people in this outdoor courtyard to access a food truck out in the parking lot. But a lot of things could happen in this outdoor courtyard, including raised planters. They have wonderful monthly barbecues that are just an absolute blast. So the more outdoor space we can allow people to visit, it just enhances everybody's life. Now, one of the better courtyards that I've been able to visit, this is just outside of London, England, in a town called Croydon, a building called Heaver's Court. It's a fairly simple 2- and 3-story assisted living building, But what they've done is it's a rectangular building. The interior courtyard is laid out in a way that it's surrounded with paving around the outside. I don't know what that is, 12 feet or so. And why I like this building so much is typically our courtyards have long winding walking paths and then one big large central gathering area for maybe a group of 10 or 12 to gather. This building provided a gathering space for that group of 10 or 12 in the middle where you see this chrome water ball. But what's so impressive to me is this band of paved surface around the entire courtyard. It's just wide enough to allow a group of 3 or 4 comfortably to gather, maybe 5, but they're all socially distanced. They all have movable furniture that allows me, visiting mom, to reorganize that space how we want. It allows, they could have 6, 8, 10 outdoor visitations going on at once, and they're all socially distanced. Acoustically, there's not going to be a lot of disruptive background noise. I think this is a wonderful courtyard. So let's talk about the small house benefits. Again, some of you already have this type of layout, some of you don't. So what we'll do is we'll talk about the characteristics just in a way that it'll help you think about some of these planning principles. And we'll show you a few examples on how people have modified their buildings to create older buildings and modify them for this method. So again, typical characteristics, they tend to be defined by how many residents and staff live, sleep, dine, and in staff's case, work together. Typically, small house grouping is defined by about 10 to 18, but we all know that number needs to be driven by your financial performance and how your staffing ratios. They're really dedicated around the premise of having a home-like environment where staff know residents better. Oftentimes, they're made up of universal workers. The greenhouse concept calls them shabazz, where they might not be broken down departmentally. Meal preparation tends to happen on the neighborhood, which makes it more home-like. The aroma from meal preparation can stimulate appetite and so on. Visitors tend to access households directly from the outdoors, although oftentimes they're also accessed or instead accessed from a connecting common portion of the building. They almost always have direct access to outdoor spaces, as we just talked about with the Byron Wellness community. Small houses can be freestanding, small groups of 10 residents, or they can be multiple interconnected buildings where they all live on their own, but they're connected to other common amenities. One of the things that small house collections, if you have a building that you can break down into this small house concept or that you already have them planned this way, is many campuses have moved residents around their buildings. And let's go back to the example of Byron. If Byron had a COVID outbreak in their building, and thank God that they haven't to date, they could move residents around temporarily in their building, and one of their households of 12 or 24 residents could be dedicated as a COVID household, and those who have not tested positive could be kept in other parts of the building. And when the epidemic is over, you might be able to move people back into the same rooms they came from, or maybe they stay where they were. But buildings with multiple small houses have allowed providers to identify COVID breakout households, and those have been very, very helpful. This happens to be planning we did for campus in Lebanon. However, these were modeled off some buildings that have been developed in southern Indiana. And this was your typical, prototypical greenhouse or small house, where 10 or 12 private rooms surround a common social space for residents where they live, dine, and play together. They almost always have direct access off a front door or off to an exterior secured patio, and they tend to have a secure area off the back where staff enter, where you have access to utilities, in this case, It was actually a combined tub and laundry room, and housekeeping, mechanical, and so on. So this is your typical small house. Although the reality is if you have a coronavirus outbreak in this building, unless you're able to contain that through an isolation room setup, which we'll talk about later, and keep that resident in their room and their door shut, and as long as staff can keep from spreading that disease, everybody's going to get it in this household unless you can take those precautions. So that's one extreme, is having a small house environment like that Lebanon building that serves only, in that case, 10 people. I think on the other end of the spectrum, Byron serves primarily a Medicaid population. They can't afford to build a bunch of 10 private resident room buildings. So again, as I mentioned before, they're set up in paired households of small house groupings of 12 residents each that all have their own living and dining, although there is the ability to flow back and forth between them. But more important for Byron is that their staff has the ability to cover more area in a way that they can afford to do that. And so this is, I think, the other end of the spectrum where we have one campus that operates a lot of households and gets the benefit of that household, but instead of serving 10 residents, are serving 120 residents in this manner. We all don't have the luxury of building new buildings or adding on to our buildings. So I'm going to share with you a few examples of how people have looked at breaking down an existing building. And we actually serve one client who has a building that looks almost exactly like this in floor plan with the dining and activity and lounge spaces laid out this way. So this looks at somebody who has a building and how do I break this down into these small houses either temporarily to help manage the spread of a disease or permanently. This is looking at how somebody broke down this building temporarily to help manage the response. And I'll tell you that some of these slides that I'm going to share did not originate in our office. They originated from the Design for Aging knowledge community that I mentioned before that I participate in. And this happens to be part of the AIA Design Response Collaborative, where members of our task force help to inform broader documents. And if you want access to those documents, they're wonderful planning guides for reopening buildings, phase reopening of buildings, and I'll try to make that available through LeadingAge, or certainly you can contact me at the information that you'll find at the beginning end of this presentation. So a way that we can break down, we can look at this building and how can we break this down is, as we talked about, small houses, the way to help contain them is to have their own entrances. If sidewalks and site planning work well, these red dashed lines could be separation zones where you could break each one of these buildings down into, or this larger building of 24 down to 3 separate households that might temporarily or permanently serve 8 residents, each with their own dining. We know the activity spaces on the virus outbreak don't get quite as much use, but in a way that we can help contain those entering a building and the residents and the staff that are interacting with one another. Another building that, an example that we've worked with, this is a provider up in Michigan that was wanting to take a very traditional building, and we've all seen buildings like this. This probably was built in the 60s or 70s, shortly after the Medicaid and Medicare program became popular, and they wanted to break their building down into more of a small house concept. So what we did is we took these 2 wings of resident rooms that were supported by common dining and activity and support spaces in the middle and added on to the building in a way that we created several households of residents. We're able to go from shared rooms to mostly private bed spaces, and additionally gives us the ability through these different access points to enter the building through these separate areas if we want to help contain a virus. And each one of these blue rectangles or shapes that you see on here tend to be staff work areas where care staff focus primarily in those areas, and it's a way to help keep residents and care staff contained within the building. So this is just a thought of how you can take an existing, very traditional, very institutional building and through an addition add on to it and break it down into different small households. Hopefully that's helpful. Let's talk a little bit about the third portion of this presentation, which is resident dining and details of resident rooms. Much of this work is shared through this AIA Design Response Collaborative that our Design for Aging Knowledge community participated in, and we want to make this information available to you because I think it's helpful. Some of the recommendations that came out of this is looking at the stage of an outbreak and how do we open up our buildings, how do we close down our buildings, and it tends to not be all at once type of an operation, but we tend to slowly open them up. As we're now learning, we tend to slowly close them down. So we talk about this idea of controls, dining controls within the building where, say in a main dining room, these next two presentations or next few slides might relate more to independent living, assisted living, but I think we'll also relate them to nursing care. So as we start to open or throttle down the dining operations, we think about how many people are dining together. We think about taking some of these tables out, and if your rooms are set up your resident rooms are set up this way, if you're using say 42-inch rectangular tables, oftentimes you can rotate the bed and set it against the wall in a resident room and convert a resident room into a temporary dining space where a resident can have a dining table in their room. This works with some resident rooms. It doesn't work with other resident rooms, but that might be a way that when you start to reduce the number of tables that are available in your dining room, you might be able to use some of those tables in the resident rooms. There's a whole other discussion that can be had in having temporarily tables located in hallways, but certainly that gets into the life safety code, it gets into the fire marshal, and how much room you are able to put furniture in your hallways, but it's also impacted by whether that furniture is more permanently fixed and so on. So there are other ways to deal with spreading out dining, even considering hallways in addition to your resident rooms. So getting back to the main controls in the main dining room, we talk about adding protective screens between residents and maybe using other common social areas of the building that you might have been scheduling very robustly before an outbreak, and now they're not getting as much use for very obvious reasons. You might be able to repurpose some of those rooms for temporary dining to help spread people out. There's some additional items I'll talk about later that get into heating and ventilating systems and filtration. And we also have more of the smaller rooms, like we talked about. If you're using one of those lounges or activity rooms, smaller activity rooms, we still want to maintain the distance. When we start looking at smaller rooms, the HVAC systems become even more critical, and how do we contain and scrub those airborne particles. Things like HEPA filters come into mind if your systems are robust enough to accept those. Also, alternating scheduled dining times for residents, or it may be alternating days. Maybe today dinner is in my room, maybe tomorrow dinner is in this modified dining room. So there are many ways to look at modifying our dining schedule. So this is just an example of a combined independent and assisted building that had dining rooms that were served by a common kitchen. And you can see the background, sort of those red rectangles. That's how their dining room used to be set up. And when we go down to this marketplace control phase 1, where we're really throttling down the number of diners, social distancing, you'll notice we're going down to 2 people per table so that we can spread people out. We're going to have plexiglass screens in the middle of these tables. These might be 2 tables parked against one another. And you can see the effect that this has is we're reducing your dining capacity down to 30 to 40% of the room's intended use. Obviously, you're going to make up for this dining capacity by providing room service, by providing dining in other spaces of the building also. So when we phase into perhaps the next phase of dining, we're able to open this up a little bit more. Now we're able to more safely allow 4 people to dine together, but we're still trying to social distance. You can see we're starting to bring in some of the traditional tables that we had before. We're not spacing the residents out 6 far apart, but now we're just focusing on keeping the group size low, much of our commercial restaurants have had to do over the recent years. So this allows us to increase our capacity of our dining room, but only up to about 50 to 60%. So it makes us all look forward to the days when we can open our dining rooms up fully again. So the reason why I show these, I'm sure you've been thinking about some of these and have already incorporated these, but I think it gives you I think these 30, I'll flip back, this idea of the totally social distance individual and the screens. Don't count on your dining spaces to be able to serve more than 30 or 40% of the people that they previously served. Whereas if we're able to just isolate groups of 2 and 4 and not spread them out quite as much as what we did, we can probably expect to use about 50 to 60% of the capacity of those dining rooms. This is another example that came from another member on the task force, where this is their traditional, a building that had a traditional dining setup, this large pizza oven and hearth and serving area, and multiple dining areas that are all served off one grill area, one kitchen. It had a capacity for 129 people, and after they went to this seating capacity, keeping everybody's chairs 8 foot apart from each other, which tends to keep people 6 foot apart from one another, doubling up tables, as you see, it broke down the capacity of this dining area again into that 30 to 40% range. And again, as we open up those controls a little bit, we're still using sneeze shields and plexiglass at the food prep areas, but as we're able to start moving more people together and dining in small groups, although still keeping them socially separate, we get back into the 60%. So again, hopefully this is helpful as you start to strategically plan for your dining and reopening those dining areas. From the small house nursing neighborhood, this is again, we weren't able to come in and take a picture of this building after it was open. This is an interim picture that was taken at Byron before they occupied the building. But this shows you an image of how their nursing food prep dining areas work. They do have they have a main kitchen where they'll bring food into hot and cold wells, as well as the short order cooking in hoods we have on these neighborhoods. And you can see in the background, this is 2 separate neighborhoods, whereas in a breakdown, we can still serve residents in these areas. And you can see, you can't see it, I guess, but just around the corner is the access to the outside. You can see some dining amenities out here on their outdoor porch. But if I cut the roof off this building and look down on it, the way this nursing environment might normally be laid out is perhaps a harvest table in the middle, some separate dining tables. We love these separate dining tables for 2 no matter what. They're great at helping to prevent the spread of a virus. But what they also do is just, we know that everybody doesn't get along, and this just helps people dine in smaller groups, and I think our residents like it that way. Or you can sit together for those who are more social, or you could also have one-on-one feeding assistants. You can see here, I'll point out around the corner in this connection between the 2 small house groupings, we can set tables along this window as well as an outdoor table here. But if we go into more of a isolation standpoint, we can separate all these tables, these little faint light circles or 6-foot circles underneath them, so you can see how we're keeping these people 8 foot apart from one another, which is a good planning. Maybe one of the things we're required to do, you may have noticed before, is our furniture layout should maintain, per our life safety code, 8 foot between the tables. will the authority having jurisdiction allow us to restrict that? I think they would. I think they'll understand. We also removed the table from this area that tends to be access to residents to the outside or for staff walking back and forth between the neighborhoods. So again, trying to keep us a little bit more isolated in addition to residents dining in their own rooms. Let's talk about those resident rooms for a minute. One of the things that I think makes us better servants to you as we get into especially areas of infectious outbreaks like this is we can start to apply some of our hospital knowledge to nursing homes. Hospitals, as we know, have tend to have more robust and very aggressive infection control risk management personnel. And we've been asked the question several times and have been asked to put the paper together on this. How can I turn my private resident room into an isolation room, a true isolation room? And we've been asked this question temporarily, and we've been asked this question permanently. So just to give you an idea, these are the requirements for a hospital infectious isolation hospital room. This is a negative air room. This is not what they call a protective room, where a room also has a positive pressure washing over the beds and negative air being pulled away. What they require, if you have an exhaust vent that extends through the roof, they require that exhaust vent to terminate 10 foot above any other exhaust vent so you don't recirculate some of those contaminated particles. They require that room to be negative air 3 to 6 times more so than what your normal air changes are in a typical nursing home resident room. The perimeter walls and ceilings need to be sealed from the spaces around them. There needs to be a place for staff to don and doff PPE equipment, wash their hands, etc. And that space is almost universally provided inside the resident room or patient room in the case of a hospital. Hospitals often have dedicated ante-rooms, but although they're not required, you can also do this just outside the room or just inside the room. We need to keep the doors shut. If we're trying to maintain negative air pressure, nursing homes normally keep the resident room doors open. We need to keep them shut. And oftentimes to maintain this negative air, we have to we need to add seals around the perimeter of that door and maybe even a door sweep at the bottom. All the surfaces in an isolation room tend to be washable. They don't use fabrics on the bedding or on the curtains that isn't washable. So they really have to think of a lot of things. And you can think about the same things if you start considering creating negative air rooms in your nursing home or in other buildings. And I know a lot of you have been thinking about this. As we think about planning new and looking at a typical existing resident room, you walk in off the hallway, we tend to have this staff zone. This can be a good location, again, in an outbreak for PPE supplies, for disposal, for hand wash. Indiana doesn't require separate hand wash sinks inside the rooms, but I'll tell you we're one of the few states who don't. This is more universally required in other states, and as Indiana will undoubtedly move toward adopting more aggressive codes or FGI codes in the future, we can expect those to be applied to our new buildings and our renovations. But the way we can look at a resident room is you have this resident zone, you have the staff zone, and this is where we can utilize our PPE. But maybe in future buildings, we look at perhaps more width of this room or more depth of this room where we can stick a dining table and have more space for visitation. You can see the impact of that in the next slide from a square footage standpoint. This room happens to be 265 square foot. And I'll also say before I go to the next one, this room happens to show access to the toilet directly off the resident zone. We like that. It provides a more secure way for residents to get to the toilet when they need to. It can help reduce incontinence because it's visually accessible. You could have grab bars going all the way to the back. But additionally, when we do get into an outbreak, it allows the staff zone to be separate from this resident toileting zone. So another way that a member of our advisory group has looked at this, just brainstorming, is they've looked at this and have grown the resident room by 26% and have explored, and many of you already have these, say these window nooks that you can put a dining table in, or it could have some chairs for visitation. That table could also be put on the, what we call the footwall here. But an additional item that they explored is having this foyer that enters into the resident bathroom that is a more robust foyer that has room for supply storage, has room for a sink. And in this case, I would argue might take a little bit too far. They're suggesting you might even have a swinging or sliding glass door where you could house a visitation with a family member in this vestibule or foyer type space, and the resident stays in the room if they're infected. My argument for that is, in reality, if infection is breaking out to that extent, you're not going to allow visitors inside your building anyway. So I wonder how useful that door is, but this is another way of looking at it. We love to explore different options and opportunities and understand the impact. There's an organization called ASHRAE, which really manages the codes and the requirements for heating and cooling systems for nursing homes, and actually for all buildings for that matter. There is a lot of information I can set you up with that they've looked at in how to create temporary or permanent negative air rooms. This happens to be a negative HEPA filtered exhaust fan that you can extend through an opening in a window, kind of like what this group has done, and plywooded up a pane of window and connected it to one of these negative air fans. And you can do that through a window. You can actually do it through your own heating and ventilating system, although if you do that, you need HEPA filtration so that you're not returning bad air into the common air. There's also permanent filters that have room for these HEPA filters. In Byron's recent building, they wanted to use PTACs, or these through-wall heating and air conditioning units in the resident rooms, and those are actually a newer style of PTAC that have a thicker HEPA rating to their filters. So they're one of the few manufacturers that have those. And if that's helpful for you to understand what type of unit does that, just get a hold of us and we'll let you know. I'm not going to go into this in great detail right now, but we've produced some white papers that I can get in your hands that compare the standards that hospitals use to what nursing homes traditionally, the strategies that they traditionally utilize. And hospitals are much more aggressive when it comes to infection control and risk management. And I know we all are taking that seriously, but hospitals have historically taken it to a greater degree than long-term care has. But just in brief overview, we very seldom design plastic laminate edge countertops in hospitals because we know those areas can chip and break. And whenever you expose wood in a countertop, you are inviting viruses to connect to that, whether this is MRSA and any other bacterial infections. Any countertops that would have traditionally had exposed high-density board or plywood underneath, we make sure that they're coated with an epoxy or laminate finish. But in general, when we design sinks in wet areas and countertops, they're always solid surface with integral sinks, oftentimes touch-free faucets, and that greatly limits the spread of infection. Window blinds are something that a lot of our long-term care and acute care customers are utilizing inside the window blinds because they don't need cleaned like, say, plantation blinds do. They don't hold germs the way fabric blinds do. Hospitals would very rarely use fabric blinds. A hospital would never use a pocket door. They'll use barn doors like you see in this image all day long, but the problem with a pocket door is that you just can't clean that pocket. The good thing about a pocket door is it gives you another place to set furniture in the room to make them more home-like, but there's just no good way of cleaning that pocket. Pockets can afford more expensive buildings, and push pads and door sensors and touchless push pads are much more expensive than keypads and some of the traditional technologies that nursing homes have used. But as we all think about COVID-proof buildings, more and more people are thinking about door sensors, ADA door pads, access sensors with fobs, with door sensors, so we don't have to touch as many things. Although the more and more we learn about this coronavirus, the more and more we are learning that so much of it is spread through airborne particles. Furniture is always cleanable. Every surface is cleanable, from floors to walls to chairs in a hospital. Usually the only rooms that hospitals allow to be carpeted are offices, sometimes conference spaces. Otherwise, everything they put in these buildings, from the finishes, again, to the doors, the walls, the floors, to the backing and seats on the furniture, are always cleanable, so they can sanitize everything. I hope this has been helpful. Again, we will provide you access. Please get a hold of me at my phone or my email. I may work with LeadingAge and the Assisted Living Association to provide an extension to this presentation to give you access to some of these links, but otherwise, I am so thankful for what you do. You rock. Thank you so, so much for caring for those who are most important to us. And if there's anything that we can do to help make your life easier, to help make your residence environment safer, please, please call. Thank you for paying attention.